Acute infarcts are hypoechoic, wedge-shaped lesions caused by obstruction of renal blood flow to the infarcted area. Bacterial thrombi are the usual cause of infarcts. Within a short time, a more chronic infarct becomes hyperechoic, wedge-shaped lesion. Eventually, the dead renal tissue is absorbed and the affected kidney may show scalloped edges due to reabsorption of the dead renal tissue. Cats with old infarcts may show a loss of the cranial or caudal pole of the affected kidney. Check for signs of current infection, such as dilated renal pelvis, cysts, high white blood cell count, or low urine-specific gravity. A patient with acute renal failure usually has a normal body condition, no anemia, an elevated serum potassium, and a smooth, normal kidney appearance or an enlarged kidney appearance on ultrasound. Renal architecture on ultrasound will be normal. Acute kidney injury often results from ischemia or toxins. With acute renal failure, the urine-specific gravity can remain isosthenuric for weeks. With acute renal failure due to antifreeze poisoning, the renal cortex may be hyperechoic on ultrasound as early as 4 hours after ingestion. Calcium oxalate crystals may appear in the urine within 3 to 6 hours after exposure. Patients with chronic renal failure usually have poor body condition, non-regenerative anemia, low serum potassium, and small kidneys with an irregular shape on ultrasound. One of the earliest ultrasound lesions is a lack of corticomedullary differentiation. This causes the renal cortex to appear thickened. Color flow Doppler can be used to identify the arcuate vessels to show where cortex should end. By the time a diagnosis of chronic renal failure is made, the initiating insult usually cannot be identified. Most cases of renal neoplasia have a guarded to poor prognosis. Approximately 48% of renal carcinomas have metastasized at the time of diagnosis. Renal cell carcinoma is the most common tumor of the kidney in dogs. Other renal tumors include fibrosarcoma, hemangiosarcoma, chondrosarcoma, and nephroblastoma. The treatment of choice in renal carcinoma is surgical removal of the affected kidney. Renal lymphoma can occur in dogs and cats. Lymphosarcoma is the most common tumor of the feline kidney. In cats, it affects both kidneys, despite being clinically apparent in only one kidney. Tumors can become infected, leading to hematuria. In cats, renal lymphoma can metastasize to the central nervous system. With chemotherapy, cats with lymphoma may have a 60% remission lasting for about 4 months. German Shepherds are prone to renal cystadenocarcinoma, showing multifocal, bilateral renal cystic lesions, multiple cutaneous nodules, and uterine leiomyomas. The associated skin lesions are known as nodular dermatofibrosis. The skin lesions are more obvious and often discovered before the kidney lesions. Lymph node enlargement and metastatic lesions from the kidneys to the liver and spleen can occur. It is an inherited condition and can occur in breeds other than German Shepherds as well. Note the large cysts that affect both kidneys in this dog. Neoplasia can metastasize from other organs to the kidneys. This dog had similar metastatic lesions in the liver, spleen, and both kidneys. Renal lymph nodes are located along the renal veins and are seen if there is pathology of the kidney. This video is from a 10-year-old spayed female German Shorthair with multicentric lymphoma. Renal lymph nodes can be easily mistaken for jejunal lymph nodes. Lymphatic drainage from the kidneys also goes to the lumbar aortic lymph nodes. Most lymph nodes inside the abdomen are not commonly seen unless they are enlarged. Enlargement of the renal lymph nodes suggests infection or neoplasia of the kidneys. Patients born with one very small kidney have renal agenesis or renal hypoplasia of that kidney. Patients usually show no symptoms. The small kidney is difficult to find on ultrasound and may not be discovered till late in the patient's life if the other kidney is functioning normally. This video is from a 9-year-old spayed female cat seen for anorexia and weight loss due to inflammatory bowel disease. The small kidney was an incidental finding and measured 17.5 millimeters in length. The other kidney was 43.1 millimeters in length. If one kidney is absent, non-functional, or removed for transplant purposes, the opposite kidney will usually hypertrophy within 6 months. Kidney enlargement is usually discovered on ultrasound. The patient is usually clinically normal and shows no urine or serum chemistry abnormalities. The enlarged kidney is hypertrophied to compensate for the decreased function of the other kidney. This video is from a 53-pound neutered male standard poodle with immune-mediated thrombocytopenia. Expected kidney size was 60 millimeters, but this left kidney was 88.7 millimeters in length. The right kidney could not be found with ultrasound. Renal biopsy is indicated when an accurate histologic diagnosis may alter treatment or management of the patient. Some renal function is lost with every biopsy. Only the renal cortex should be biopsied, not the medulla. Renal blood vessels gradually increase in size from the cortex toward the renal pelvis. Medullary biopsy can result in infarction. Renal biopsy is unlikely to alter treatment or prognosis in patients with acute or chronic renal failure. Biopsy can affect management when neoplasia, amyloidosis, or protein-losing nephropathy is present. Cytological results of lymphoma are definitive. Because the kidneys do have pain receptors, the patient should be under anesthesia for a renal fine needle biopsy. Transducer pressure and/or digital pressure can be used to help push the spleen or transverse colon out of the way. It is easiest to biopsy the caudal pole of the left kidney, although either pole of either kidney can be biopsied. If both kidneys appear similar on ultrasound, only one kidney needs to be biopsied. The kidney can also be surgically biopsied.